announce it. And now I'm going to go ahead and turn it over to you. Please go ahead.
All right. Thank you, everybody, for joining. As Liz mentioned, my name is Michael Comisac. I'm one of the third-year residents here at the Kootenai Health Family Medicine Residency up in Coeur d'Alene. Just to give very brief background about me, I'm originally from Pennsylvania, moved out here because I was seeking rural critical access type of practice for my future, which have gotten a lot of exposure to out here. But with that, kind of moving back east, and we'll be doing a rural critical access type job that is going to include potentially lots of house calls. So I decided to do my Grand Rounds presentation and kill two birds with one stone and look up the evidence behind home-based primary care, house calls, how they impact our patients, do they improve outcomes, et cetera, et cetera. So just to kind of dive into it here, talking about the value of home-based primary care. No disclosures. A third-year resident. I am not paid by any organizations except for the residency itself. Objectives, very briefly. So gonna do an overview, kind of talk about what is HBPC, talk about some of the history, barriers and challenges, benefits that have been cited that come as a result of home-based primary cares in different organizations across the US, why it's relevant. We'll do the bulk of our time reviewing evidence regarding home-based primary care and house calls. We're going to talk about reimbursement because I'm sure a lot of you are already imagining some of the challenges coming with the time that it takes to do house calls and things like that. We're also going to talk a little bit about incorporating home visits into an existing kind of normal office-based practice. So going into that, so an overview about home-based primary care. A lot of this is taken from the American College of Home Care Medicine, but really the goal of this is to deliver patient-centered care to underserved peoples who have a lot of difficulty with adherence to the traditional office-based healthcare structure. People who have impacted social determinants of health, people who can't get out of their house because they don't have a ride, or they can't get in the car, they don't have the ability to drive themselves, or they're elderly, frail, they just don't want to come, they have cognitive impacts that impact their ability to be able to make it to appointments on a regular basis. Those are the people that were really home-based primary care organizations are really trying to improve outcomes for. Naturally tries to fill a critical access gap for these people who have difficulty adhering to the typical healthcare structure that we have in primary care across the US. Other things, just as part of an overview, it is most effective when performed as a multidisciplinary unit. That's something that's kind of reinforced through a lot of the evidence that we have available to us, is that when you incorporate a social worker or a nurse or a PT or an OT or an ST or a combination of all of those things, as many as you have access to, patient outcomes are improved whenever you have access to those other people's beyond just a physician or an advanced practitioner or something like that. Other things that this does, you really get insight into people's lifestyles. Personally, I've done a few house calls in residency, and you'll be shocked at how some people live. Either you're expecting the worst, and you walk in and you're like, oh my God, this situation is actually great, or the opposite. You get a little bit of insight into how are they storing their medicines? What hazards do they have? Why is this person continue to fall? Why is this decubitus ulcer not healing, right? You can do much more comprehensive geriatric assessments. We'll kind of dive into a couple of those towards the end. You can do home safety assessments, medication reviews, as I had talked about. You can, review medical equipment, make sure they're using their walker appropriately, make sure their nebulizer is working. One of the main goals is also to just support functional independence. If you have high healthcare utilizers, sometimes it can seem like all they're doing is going to the doctor's appointments, and they're never actually able to stay at home for a day and just enjoy themselves. The other thing that we'll see in kind of the evidence review is that very, very, very likely to reduce emergency department visits and hospital admissions. So we'll dive into that a little bit more. Why is this relevant? Couple of things. The first thing, and most of the information that's available to us through the different studies that have been done, is focused on healthcare spending. So no surprise, that's kind of where a lot of the research is driven, is how can we decrease specifically like Medicaid and Medicare expenditures, and is home-based primary care appropriate to do so? So I have some numbers kind of listed up here. This is purely for Idaho Medicaid expenditure report at the end of the last fiscal year, $4.786 billion in Medicaid alone. 20% of that comes from hospital-related costs. Hospital-related costs include actual hospitalizations and inpatient stays, surgeries, and also emergency department visits. In 2019, most recent data available, average adjusted cost of one hospital stay across all insured age groups in the United States was about $14,000. So preventing one hospitalization in theory could prevent on average, $14,000 in healthcare spending. So in 2022, 155 million ER visits, not necessarily people visited the ER, but ER visits in total. 47 per 100 persons, which is a pretty striking number. 17.8 million hospital admissions. And then the next point really is older people are utilizing the emergency department more regularly over time. So it's been a pretty slow and steady increase from 1997 until today, over the last 20 years or so. But every couple of years, whenever this data is reaccumulated by the CDC, there is a small increase in the amount of people that are utilizing an emergency department over the age of 65. So 26% of seniors in 2019 had an emergency department at some point over the course of a year. And then the other big part is that our population is getting sicker. They are sick and getting sicker, and they are aging. 129 million people in the United States have at least one major chronic disease, according to the United States Department of Health Services. Increased prevalence over the last 2 decades, 42% of those 129 million have at least 2 or more, and 12% have at least 5 chronic illnesses, hypertension, diabetes, osteoporosis, all of those things. This kind of outlines that social determinants of health. So this is from CDC data. What this does is it breaks people up into their income related to the poverty line. And then it shows the percentage of people who live within these categories and their emergency department utilization. So what we see here, and this is not adjusted for age, except for it includes all adults. So this does not just stratify for that 65 plus age group, which we talk about a lot in this presentation. What you'll see is that the poorer you are, the more likely you are to use the emergency department. Greater than 30% of people who live below the poverty line have utilized the emergency department pretty consistently over the course of the last 10 to 15 years or so, with a little bit of an increase from 2017 to 2018, interestingly. This graph is from the United States Census. This helps to kind of outline our aging population. It's something that we're all aware of. Sometimes it's helpful to see it in a visual form. So the different squiggly lines in different colors are basically different years separated by 10 years, with the blue line being 2000, the green line 2010, the orange line 2020. And this is absolute number of peoples who report this age on the US Census. So as you'll see, really the biggest gap is going to be in the age 55 and older, is where the graph really starts to separate itself. We've gotten very, very good at keeping people alive for a long time with chronic illnesses, and we've gotten very good at treating things that have otherwise killed people in the past. And what that has resulted in is a significant variation in the age distribution of our population. It's been pretty steady throughout the people's aged 5 through 45, and then it really starts to break open because, like I said, people are living longer, especially in that 65 plus age group. This is another way of representing the same exact information, just a different visualization of such. So you may have seen these before, but all the way on the left there, that's 2000. And then all the way on the right is 2020 with 2010 in the middle. And you'll notice that the graph gets a little bit more kind of quote top heavy the further to the right that we go, with a larger absolute number of individuals aged over 65. So history of home-based primary care or house calls. Pretty fascinating, but in 1930, 40% of all medical care, that includes hospitalizations, people weren't hospitalized at home, but 40% of all medical care occurred in a home-based manner. House calls were the norm, which is just crazy how much it's changed over the course of the last 100 years or so. In 1950, that was down to about 10%, and in 1980, down to less than 1%. So over the course of 50 years, home-based care essentially vanished. In 1997, there was a pretty, famous in this realm, at least, article published in the New England Journal of Medicine that they basically found that only 0.88% of Medicare patients over the age of 65 had received a house call from any physician, and almost all of them were towards the end of their life. So just illustrated that, house calls had been dead essentially. Over the last 20 years, that has been changing for sure. So you'll see there just 2 years or 3 years ago now that it's 2026, 2.5 million home-based visits occurred in patients enrolled in Medicare and Medicaid in 2023 compared to 1.7 million in 2013. So over 800,000 more visits over the course of 10 years. So I decided to look into, why exactly is this the case? Pretty multifactorial, but you'll see some of our data that we've acquired occurs over this time period. There's been addition of CPT payments. There's been increases in reimbursement for appropriate primary care. Advancements in point of care technology has definitely advanced people being able to receive, at least close to the standard of primary care in a home-based setting. And all of those things have been attributed to kind of the resurgence. So what barriers do we have, right? Why can't we just go to everybody's houses and, give primary care in a setting that is patient friendly? Well, it obviously is going to decrease your productivity. You can't see people with the same level of regularity, or I guess the same number of patients in a day that you can in an office setting. Pressure to increase productivity was cited as one of the reasons primary care had kind of declined over the course of those 50 years. Really poor reimbursements for a long period of time. You would have to bill them just the same as you would any other office visit. And there was no difference in the amount of reimbursement that you got from house calls. So physicians had less incentive to provide home-based primary care. The coordination to do so has been listed as a major burden and a contributor to burnout. So like right there, the 2014 analysis at Mount Sinai's home-based primary care program estimated that 20% of their time was spent in care coordination. So arranging the people that you need to go, transport, all of those things, and none of it was being reimbursed. Came up to 4 to 8 hours a week. And this is for a dedicated home-based primary care program where this is what they do. They do not have this is separate from their standard like office-based practice, and even trying to streamline it as much as possible, they were still coming up to 1/5 of their week being not reimbursed, which makes it seem not super feasible. Home-based primary care practices themselves, who kind of fall into that same program as the Mount Sinai program, different challenges that they cite as being a major barrier to this becoming more commonplace in the United States. One of them is provider retention. Burnout is a big one. These are frail, medically complex patients, those people who benefit from home-based primary care, kind of in that overview slide. If every single one of your patients is frail and medically complex, they can get really challenging, especially if that's all you're seeing all day. Unmet demand for services. So there's, millions of people who qualify for the Medicare definition of homebound, but there's not enough providers providing home-based care to be able to meet the demand for a lot of these home-based primary care programs. And then the other thing is charting is more difficult whenever you're in somebody's home, right? You have to have your EMR integrated, and you have to take time to sit down and actually be able to write stuff down. I mean, if you're driving from patient house to patient house in between, you're left with a lot of charting at the end of the day, potentially, especially if you're not a very efficient and streamlined program. So why do it, right? This seems like a lot. We have a pretty good thing going with our traditional office-based care. So that's what a lot of our evidence review focuses on. And you'll see some of these things here are kind of reiterations of what we talked about earlier. Healthcare system cost savings is a big one that we'll kind of hone in on. Patient satisfaction is another huge one. This can reduce feelings of loneliness, isolations, makes people feel more cared for. This allows for more appropriate lifestyle education, assessment of medical equipment, all of those things we kind of talked about earlier. So let's do it. Let's dive into some studies. This is the first one. This was a pretty large study that was done by the VA. A lot of the information that we have available to us regarding home-based primary care in particular is through the VA because they have a very robust program that provides house visits for chronically ill individuals. This was a pretty big one. This was a study that retrospectively looked at newly enrolled HBPC recipients with the cost of care being the primary endpoint. Now, really what I tried to do was boil these studies down to as small as possible for you guys. I have at the end of the references have the complete studies if you want more information regarding them. But the biggest thing that they noticed with this study in particular, looking back over the course of a year, is that their Medicare costs were 10.8% lower than expected. Now, this is not controlled, right? They base this off of what is the amount that we are expecting to spend for this group based off of information that's available for Medicare patients previously. VA plus Medicare costs 11.7% lower than they had anticipated. So that's a pretty significant cut whenever you're talking about expanding this across, a large portion of Medicare and Medicaid. To cut 10%, we're talking millions and millions of dollars of potential gain there. The other thing that they noted was combined hospitalizations were 25.5% lower than expected during that period than without home-based primary care. So they, have similar data where they kind of extrapolate how many people they expect to become hospitalized, and they noticed that a fourth of them or hospitalizations in total were, 25% less than normal. That's also quite significant, especially when you consider the cost associated with a hospitalization. The big thing is there was very high satisfaction. The N equals only like 40 survey participants for this, but this kind of rings true throughout a lot of our other studies as well. Another one, this one also done by the VA home-based primary care program, was a little parlay off of the previous study where they wanted to look at our outcomes, right? Are our outcomes different? We've demonstrated that this saves money, but is it actually benefiting patients? So this was over the course of fiscal year 2015 to 2017, with our primary endpoints being hospital stay, acute care service utilization, ER utilization, mortality, and things like that. 10,000 people, many of which had many chronic conditions. What we found was that there was significant decreases in hospital utilization and acute care services once again. There was no difference in mortality between the two groups, which you could argue is either in support of home-based primary care or against home-based primary care. Is it that we're providing the same level of care and we're having no difference in mortality? Or is it that, this doesn't actually benefit patients, it only benefits the healthcare system? Hard to say, and kind of dive into that with a few other studies as well. But these are pretty big numbers, right? 41% of individuals were expected to have hospital utilization at some point, and emergency department falls into this category. And this decreased to 25%. And then non-hospital acute care services like urgent care visits went from 34% to 11%. It's a really big reduction. And this is for people who had been enrolled for 6 months. And these were only home-based primary care. They were not having any office visits. They were only having doctors come to their house, except for subspecialist visits. They would still go to their subspecialist offices. It was only primary care. So pretty interesting. 84% of the last 180 days of life for the 36% of the study population that died were spent at home as well. I have no reference to whether, that is comparable to what people are spending outside of home-based primary care, but they felt a specific need to highlight it and talked about it a lot in the discussion. So I would imagine that they viewed it as some sort of, increase in the amount of time spent at home. Next study, this one was done in Spain, and it had a small number, but I liked it for a couple of different reasons. It was led by nurses, so it had a little bit of a different structure. They didn't have any kind of MDs, DOs, or NPs or anything like that going out to see patients on a regular basis. They did a retrospective evaluation of a program where they had nurses coming into the house and doing assessments and education and things like that. The reason it got stopped was because of COVID. They specifically did not include people who were palliative in the end of their life based off of a clinical risk tool that they had utilized. So these are people still seeking the standard of care who are coming to the office, but having some level of home-based care with nursing interventions. So the key endpoints here were purely hospital admissions and emergency department visits. I also decided to include what were their criteria for the home visits, right? They had to do all of these things for it to qualify as a home-based primary care visit. And this was completely nursing driven. So, they were basically doing TCM visits with nurses at home. They were doing systematic reviews of medications. They were assessing pain, doing eating education and things like that. All things that, if we were to incorporate home-based primary care house calls into our practice, things that we could do to achieve the results that they achieved, which was really significant decrease in inpatient utilization costs and inpatient utilization overall. The most striking is the emergency visits. So within this study population, albeit it is on the smaller side, the orange is the intervention group, meaning the people who had received regular 3 nursing visits per year. 51% of those people had greater than 10 emergency department visits over the course of a couple of years, compared to 5% in the investigational group. And then, you can look at the rest of the data for yourself. Hospital admissions also significantly decreased in the intervention group. So just by having somebody come out and provide education, even if it's not a provider, can result in, major reductions in utilization. And, they didn't dive too deep into actual outcomes for these people, but it kept them out of the hospital, which, good thing. So this goes back to the United States. This is one of the only currently published randomized clinical trials that looks at outcomes for home-based primary care for homebound older adults. New York City, so a little bit of a different environment than, where a lot of home-based primary care has the opportunity to thrive in rural environments where people have a little bit more difficulty with transportation and things like that. But nonetheless, a little bit of a smaller recruitment as well. You'll see N equals 229 down there. What this basically did was they did home-based primary care versus office-based primary care as the control. So one group was only receiving home visits, one group was only receiving office visits, who had reported at least one hospitalization in the last 12 months. So these are people who likely have multiple chronic illnesses and met the Medicare definition for homebound. 12-month follow-up, they looked at outcomes including symptoms, satisfaction, hospitalizations, ER visits, and they found that the intervention group had significant decreases in their hospitalization rates with an absolute risk reduction, 17.9%, a number needed to treat of 6, which that's pretty darn good over the course of the 12-month follow-up timeline. However, what they found was there was no difference in quality of life, symptom burden, interestingly, emergency department visits, and there was increased mortality in the intervention group compared to the control group. So, 24 deaths compared to 12 deaths. This is actually what led to the study being terminated early. I guess the IRB wasn't too keen on, them continuing to run a study where it's clearly showing that mortality may be increased in the group that you're intervening upon. So pretty interesting data there. And it's one of our only randomized clinical trials. So there's definitely more study needed to be able to determine, is there actually an increase in mortality for, some of those barriers and challenges that we had talked about earlier. Are these people receiving the standard of care when they're getting home-based primary care, or could we improve their mortality, with our traditional kind of setting that we have now? Next study. This was a study that was a little bit different, and this basically talks about healthcare utilization costs as well. So this was done at the MedStar Washington Hospital, and this was also a retrospective study, and it's kind of, similar view as a lot of the other studies. 17% lower Medicare costs, averaging $8,477 per year per beneficiary. There was no difference in mortality or average time to death in these groups. And the one thing that was interesting about this is that people were less likely to see their subspecialists, but they had over double the amount of primary care visits that they were expected to have, or compared to the control group in the traditional office-based setting. Independence at home demonstration is probably the largest amount of data that we have that relates to home-based primary care in particular. Basically, they took the VA information and and they wanted to try and replicate it on a larger scale across different populations. So, using the information provided to them, Congress mandated a study basically where they offered payment incentive to HBPC programs, and they wanted to determine, is this something that is scalable? And is this something that, will ultimately end up resulting in less healthcare utilization? This does not focus on outcomes. This purely focuses on spending. So you can see the eligible beneficiaries there. 2+ chronic conditions. They have to have deficiencies in walking and bathing and feeding, or at least 2 or more activities of daily living being impacted by their chronic health status. And they must have received some sort of acute or subacute rehab in the last 12 months. These needed to be led by physicians or advanced practitioners. They needed to provide physician level services, and the people that they enrolled in this demonstration was programs that had experience, and they had at least 200 established patients before they were able to participate in the demonstration to avoid for any confounding factors. What they did is they did quality measures, kind of similar to Medicare and Medicaid quality measures that exist throughout traditional standard practices. And they set target spending data or they set target spending amounts where they were estimating how much these people the patients based off of their, comorbidity and other statistical analyses and things like that were going to spend. And then the home-based primary care organizations tried to meet the same level of care and get those quality measures at less cost. And if they did so, then they would be reimbursed with a portion of the savings that were created by their care. So what did they find? Very interesting. So it started with 18 groups For some reason, year one's data is not available on the CMS website where all the rest of the years were available. But by year two, they were down to 15 groups, and they were very successful at saving money across the board. So you can kind of go through there. What this basically says is that in year two, they spent $10 million below the target spending across 10,000 beneficiaries. Oh, my lights went off. $1,000 per beneficiary. There we go. Keeps going. Interestingly, year six, they were down to 11 practices. And that number seemed to jump quite considerably. So from $2,000 to $5,000 per beneficiary with similar savings across the board. By year seven, it was down to 10, and then 7 practices whenever the pandemic had hit. And then year 9, those 7 practices remained. And then year 10, they were saving $18,000 per beneficiary, which is just astronomical if you were able to create that on a large scale across the United States. But there was only 1 practice. The reasons for attrition were really difficult to find. The only thing that I could see was like one article. They kind of talked to one of the programs about why they dropped out because, I mean, programs are being reimbursed millions of dollars based off of this. There were really, really strict requirements and really high standards of performance to be able to receive the incentive pay, which ultimately led to them continuing to do home-based primary care, but not being involved in the independence at home demonstration anymore. A lot of scrutiny from organizations that analyze this data that talk both about the creation and oppose the creation of like a permanent plan to incentivize HBPC practices. You know, it's hard to say exactly why some were so effective and some not quite as effective, but it's clear that some of them are doing better at saving money than others, whether that comes at the cost of standard of care. You really need more information to be able to make that assumption or be able to take any data away from that. So there are, you know, like I mentioned, some randomized clinical trials that are currently recruiting. There are some that are currently in data collection, and they're trying to look at this more. The independence at home demonstration looks like, unless they're able to recruit more practices to be able to contribute, is probably going to be coming to an end before too long, but it does continue to get extended because of the money that is saved by congressional action. So what do you do? What is all of this information for? How do we look at this and come away with some sort of rational conclusions? This is what I came away with. There's lots of different ways that all of this information can be interpreted. The one thing that kind of rang true throughout a lot of the studies that were done is that patient satisfaction was higher regularly in most of the studies. People felt more cared for whenever they had people coming into their home, which intuitively makes sense. On average, the home-based primary care does decrease healthcare spending. That is very clear throughout every single piece of data that we have available to us. Healthcare dollars are less whenever healthcare is delivered in the home. Probably results in decreased rates of hospitalization, ED visits, and acute care utilization. We only had that one kind of mixed review where the randomized clinical trial had the same number of emergency department visits, but across the rest of the board, you're seeing significant decreases in the amount of hospitalizations, ED visits, and urgent care visits, and things like that. The other things that's important to take away, this is probably not sustainable for the vast majority of physicians that are in the United States. Running a home-based primary care program that is effective takes a lot of coordination. It takes a lot of resources, and you know, we are just not set up for that across most of the United States at this point. So doing it by itself, probably not sustainable. It also might not make a major impact on mortality. Hard to say, you know, are one RCT getting terminated earlier because of increase in mortality? You know, it's hard to say whether you can pull away a ton from that because it was a pretty small sample size, but it shouldn't be ignored, and more study is certainly needed. Home-based primary care certainly does not seem to improve mortality by any means, even though it decreases hospitalizations. So occasional house calls is kind of where I came came to my conclusion. This is probably, if feasible for your practice, the best way that we can try and prevent hospitalizations and emergency department visits while still providing, a level of regularity that's feasible for the physician, and also, not significantly impacting the long-term outcomes of our patients. It's one house call per year, three house calls per year, like the nursing intervention that they did in Spain. You can ensure that continuity of care. You can make sure that that person is being seen by somebody, even if it's not just a physician, or if you have, nursing resources or something like that. You can improve relationships and patient satisfaction. You can likely improve end of life care. Up here we have a great hospice organization that helps to take over end of life care for a lot of our patients who qualify for that. But that's not the case all across the United States and some of our more rural environments. We can lower healthcare costs by lowering ER utilization and hospitalizations. We can get that insight that I kind of talked about at the top, see the chair that they sit in all day and why they get the ulcer, and see how they store their medicines, all of those things. Increased reimbursements compared to office-based visits. So if you're able to create any level of scalability or see multiple people in the same area at the same time, you actually can increase your productivity from like a reimbursement standpoint or RVU standpoint, which we'll talk about in a couple of minutes here. The other thing to note is that there is no data basically that I could find that compares traditional office-based practice to a multimodal care setting. So we don't know if, the occasional house call makes a big difference. We don't have the same information available to us to be able to say, I'm going to significantly impact this person's mortality because I don't have all of the technology available to me whenever I go and make a house call. And same thing, you don't know if you're going to be able to significantly decrease their ER burden or their hospitalization burden and things like that. So need more info on whether it's actually helpful or not, but seems to have some definite positives to it. One study that they did on like house calls in particular, this isn't like a comparative study, but it is a retrospective analysis that they did at the Mayo Clinic. They had their patients have an on-demand house call platform, which is striking, where they could go on an app and request a house call from a physician, and then they would come out and do it. They found that almost all of this was being utilized for acute same-day visits, and many of which being children, like ages 1 and under, where they would have a primary care doctor come out and do a visit and provide recommendations. The mean visit time, not including travel, which is important to note, especially if you're living rurally, was 27 minutes. Most people did it because they wanted it to be convenient more than anything else. But the biggest thing is that 94% of people said that they would do it again, which points to kind of, patient satisfaction. People felt like they were getting adequate care in their home-based setting and not having to travel to an office for it. And you also help to, prevent like, somebody coming into your office and exposing your entire care team to respiratory infections in your waiting room and all of those kinds of things. So kind of interesting data there, but doesn't exactly look at the kind of, home-based primary care continuum with our elderly folks receiving chronic care. So reimbursements, this has changed a lot over the last few years, and this is likely to continue to evolve. So I had to go through 4 or 5 different articles for different updates over the last 10 years to finally land on what the appropriate documentation to be able to input it into the CMS RVU calculator to be able to sort out. The AFP has a great article on guidelines for documentation. There's also a great guideline or guidelines for, what can I code, what can't I code for home-based program or home-based care and things like that if you were to end up doing a house call. But just looking at an example, 78-year-old patient, a lot of kind of bread and butter stuff, has an amputation, has a lot of difficulties, family's concerned that they're falling. And you do a house call and you involve the family members, you bring a nurse, you do a detailed medication review, you look at how they're storing their medicines, you do a nutritional assessment, you do a safe at home checklist, which I have on the next page as an example. You discuss advanced directive paperwork and you decide that PT and OT is appropriate. Seems like a pretty reasonable visit for somebody who's having, falls and things like that. For billing purposes and like how you would bill this and how it could be reimbursed, all of the things that you can bill for: chart review, history, evaluations, counseling, education, ordering tests, documenting, and all of that care coordination with family, which is really helpful, especially if you're like on the phone and trying to make sure everybody's in the same place at the same time. It's not unreasonable to think that this is going to take over 60 minutes of your time. And you can do the time-based billing to get you basically to what is the equivalent of an office-based level 5 if it takes over 60 minutes. The interesting thing about the home-based care is that the G0318 code, which is relatively new, allows you to bill for additional costs if you go beyond 109 minutes of total care provided. So pretty decent bump in the amount of RVUs compared to an office-based level 5 with 3.6 for the base E&M code alone compared to 2.8 for the office-based. And then, of course, you don't forget about your advanced care planning, home health certification, and then that G2211 code. But the nice thing about it is that even beyond the productivity, you get to do like a safe at home checklist, right? You can go through and you can look at things and determine what are our major risks. And these qualify as medical interventions. So, these all count towards your time-based billing, but you can, make recommendations on clutter and chairs and, transfer modalities and, who's in the house, be able to do a nutritional assessment and things like that, be able to provide, food label education and talk to people about salt intake, all the things that we try to do in the office that people seem to forget the second that they walk out of the door, with a little bit more regularity and probable success. So a few miscellaneous tips. Really, the biggest thing is geographical planning. If you could, let's say you're in an environment that has an assisted living facility that doesn't regularly have a physician providing care in that setting, you can go and see multiple patients at the same time, and you can really maximize productivity and still utilize that kind of home-based billing modality to be able to really, you bump up those RVUs to the point at which you're making the same, if not more, than you would on a regular office day. The biggest thing is that travel time is not reimbursable. So if you're driving an hour to go see a patient, then you're driving an hour in another direction to go see another patient, that's 2 hours that are lost, that are just not billable, despite all of the other work that you do kind of on the back end. Other tips, a lot of this was taken from that AAFP article that I had talked about in credit on the next slide here. Environmental hazards, bed bugs come with you, pets, weather, firearms, making sure that you have an exit plan and things like that if you are going to be doing a house call. Bringing care team along with you, not only for safety's sake, but also because it'll make you much more efficient. If you're doing a medication review, you can have somebody doing one thing in one room and you doing a physical exam and your history collection in another room with family members and things like that. You can really do a lot to help prevent your patient becoming hospitalized or using the emergency department in a relatively short or reasonable amount of time. And then you want to be prepared with equipment. This is something that I was not prepared for whenever I did my first house call. I did not realize how much stuff I would actually probably need to be able to perform the standard of care. This is kind of the modern day black bag checklist that the AFP provides. This is probably more stuff than I would anticipate bringing along with me, but it gives kind of like a baseline framework on things that might come in handy for folks depending on what are their needs. The only thing that I would add on here that I didn't see whenever I was looking at it the first go around would be like a point of care ultrasound, especially as that continues to develop and primary care doctors become more skilled in using primary or point of care ultrasound. It can really garner a lot of information quickly. So that's what I have. Here's my references. I'm available for questions. I wasn't monitoring the chat at all. So I'll open it up for anybody if they want any clarification or questions.
Yeah, Dr. Comisac, could you go back to your references slide? That is, I think people, well, while they answer questions, we can have that pulled up. And I was dropping stuff in the chat because we had people joining all throughout. Great turnout today, everybody. Thank you. Thank you to Dr. Comisac for a really interesting presentation. Does anybody want to put a question in the chat or unmute? Offer any feedback. Please go ahead. I think I heard somebody unmute. Maybe I made that up and
it was
just
an
thought I
accidental unmute, but I actually did have a question, or not really a question as much as anything, a comment, because I've seen other home-based care models. There was one in San Francisco I saw, and then when you start looking at the resources we have in Idaho, the physicians per capita in San Francisco, primary care physicians per capita is something like 3 times what we have in Idaho. I looked up in New York City, it's at least 50% higher. In Manhattan, maybe as high as threefold physicians per capita in Manhattan, where that first study that you talked about took place. That's always the thing that has been, in my mind, a limiter for doing more home visits or more home or community-based medicine, is it's just inherently inefficient, and we're already understaffed in Idaho. So that was maybe a comment, and if you want to respond to it.
No, and that's one of the biggest challenges, right? You're trying to see as many people as you possibly can, and there's a lot of benefit to be had, but it's just not feasible for your everyday physician at this point, which was kind of one of the big purposes of me going through this is this worth it? Because you sacrifice so much of that time. Does it make that much of a difference in terms of patient outcomes and things like that? So, yeah, I thought it was a interesting rabbit hole for sure.
Great. Thanks. Any other questions or observations, anecdotes that people would like to share? You're welcome to use the chat or unmute.
I had a question. How does this compare with home health services versus home-based primary care? Because home health services we can prescribe in Idaho, and that's a lot cheaper than us going out.
Yeah, and I'm getting a lot of feedback. There we go. Yeah, so it's there's no head-to-head studies, and that's one of those things that I feel like needs more attention paid to it, especially with how promising some of the data, especially regarding healthcare, spending is concerned. So it's unclear whether, home health services benefit the population the same way that a true home-based primary care does. Whenever we talk about significant decreases in spending and utilization and things like that, I would imagine that, if they do in these randomized clinical trials, that they're not going to exclude people who are receiving home health services, because that's kind of like our standard of care at this point. But it's one of those areas where we just need more information. And I think that study that they did in Spain with the nursing resources really kind of show that you'll have significant decreases in utilization of ERs and hospitalizations, even without a true physician presence at these home visits, as long as they're standardized and accomplish a certain subset of goals.
Great. Any other questions? Please unmute or drop your question into the chat. And I'll just mention again that in the chat, you have both the link to the Google form or directions to email me so that you can get CME for this event. This was, it'll take about a month before we issue the certificate on that. But if you need the CME, please let us know. And I also dropped into the chat the registration link for the IAFP annual conference that is taking place May 15th and 16th in Ketchum. We have a great program lined up for everybody, and we would love to see you at that event. And the next Grand Rounds is going to be on February 9th. And we expect that to be from the Full Circle Health NAMPA program. So we hope that you can join us again on February 9th. I'll stop talking for a second just to see if anybody else. Well, we have Dr. McLandris saying excellent review, Mike. Thank you. Thanks for being here, Dr. McLandris. Yeah, you did great, Dr. Comisac, and you had amazing attendance. So we love that.
Thank you so much for having me.
Yeah, is there anything else you'd like to say before we finish up?
No, I've talked enough at everybody.
Okay. Well, I did also just want to let people know that the IAFP has started a workforce and rural support forum. We just had our first last week for rural providers and health systems or those affiliated. We had great attendance. Our topic was on the nursing shortage. And the next one is scheduled for April 16th at 5 p.m. Pacific time, 6 p.m. Mountain. I apologize. For some reason, I can't seem to find the registration link right now. But that will be showing up in an e-news. And as I said, if you wanted to save it on your calendar, it's going to be April 16th at 5 p.m. Pacific, 6 p.m. Mountain. And Dr. Kelly McGrath is going to be talking about OB competency. So it should be another great topic. This recording will be available in the IAFP CME library. If you go to our page under publications, you'll see the link to that. It's not available for CME credit, but it is available for viewing. It won't be up for about a month. We have a lot going on. The legislature convened today, but we were happy to have this opportunity to talk about this important topic. Appreciate you, Dr. Comisac, and all the attendees today. Everybody have a wonderful day. Thank you.